Eye is window to many hidden systemic diseases. Here is a story wherein an eye gave clue to potentially lethal condition. She is a 46 years old lady who was treated for adenocarcinoma of lung with secondary metastasis to bone and was in remission since last 6 months. She was diagnosed to have RD and advised vitreous surgery elsewhere. Fundus showed total bullous retinal detachment almost behind the lens. B scan showed large bullous retinal detachment with echolucent subretinal space and a flat lesion in the superior quadrant with high surface and moderate internal reflectivity. So, our clinical diagnosis was exudative retinal detachment secondary to metastasis. UBM was done to rule out lesions in iris and ciliary body. We planned for phaco-vitrectomy and external drainage and FAX, and patient was clearly explained the need of oncotherapy post-surgery. Phaco being done to create space in anterior chamber for placement of AC maintainer and anterior placement of infusion cannula. Conjunctiva dissected in inferotemporal quadrant. With hockey stick knife, sclerotomy done 6 mm behind the muscle ring and choroid was exposed. 4 mm infusion cannula placed and confirmed its intravitreal location. Suture taken as a guard. Exposed choroidal knuckle punctured with 10-0 suture needle. Yellowish subretinal fluid being drained. Infusion put on now and further SRF was drained. Sclerotomy was sutured. Standard 3-port vitrectomy being done. PVD induced. Flat subretinal yellowish bumpy lesions seen in superotemporal quadrant. FAX done, and that's it. No need of retinopexy or tamponade. Routine post-operative eye care was advised. At consultation with oncosurgeon, MRI revealed metastasis in temporoparietal lobes and posterior superior wall of orbit. Whole brain radiotherapy initiated. NGS revealed KRAS Pg12V, which is a driver mutation, and therefore immunotherapy was also proposed. So, in this case, retinal detachment drew our attention towards the recurrence. Clear lens extraction is mandated for placement of anterior chamber maintainer or anterior placement of infusion cannula. PVD induction with near total vitrectomy along with external drainage and FX is all that is needed. Tamponade and lasers are not needed in exudative RD management. So friends, look beyond the obvious. Such subtle eye signs can lead us to systemic disease, and therefore fundus is called as the camera to the systemic diseases. Thank you.